Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Betul.
Salah betul.
Semua ada kan?
Macam ada lagi yang tak masuk.
Semua ada berapa ramai?
29.
29.
Betul.
Kalau rasa macam dah ready semua, kita beritahu eh.
Ada soalan lagi, Doktor? Doktor, there's one person, but she having an internet problem, so we can start first, I think. Sorry. Before that, let's start our class with Untitled Chapter.
By the way, kena ni kena on video untuk attendance.
Can you see my slide? Hello.
Yes, yes.
Yes, yes.
Assalamualaikum warahmatullahi wabarakatuh. Very good morning. I'm here to Dr. Alwi and my fellow colleagues. So welcome to our first teaching seminar of this blog. So today we're going to talk about gastrointestinal problems in pediatric population. We have four topics today. We're going to talk about chronic diarrhea, chronic constipation, liver failure, and last one is functional abdominal pain in children. So today I'm going to talk about chronic diarrhea in children. So first, these are my outlines. First, I'm going to talk about the definition, followed by pathophysiology and the causes, and then how to approach those children with chronic diarrhea. And I will end the presentation by giving an overview of the common diseases which present with chronic diarrhea. So first one, this definition. So according to Nelson textbook, the definition of diarrhea is divided into, is according to the age group of the patient. So in toddler or infant, the diarrhea is defined as excessive daily stool liquid volume more than 10 grams kg per day, whereas in older children, it's defined as diarrhea when the patient has stool volume more than 200 grams per day. Now, the problem with this definition is that nobody really measures your stool volume, isn't it? So the more practical way of defining diarrhea is to define it as the passage of 3 or more loose or liquid stools per day, or more frequent than is normal for the individual. This is more practical and it's much easier for you when you're taking history and so on. Okay, so diarrhea, like most of diseases, they have acute and chronic forms. So it's very simple. Acute form is when patient has diarrhea for less than 14 days. And chronic diarrhea is when the patient has diarrhea for more than 14 days or 14 days or more. So this the pathophysiological classification of diarrhea. We can divide it into four. We have osmotic diarrhea, secretory diarrhea, inflammatory diarrhea, and fatty diarrhea. So the first one, osmotic diarrhea, this is caused by the presence of non-absorbable nutrients in intestinal lumen. How? By ingestion of poorly absorbed substance or malabsorption. So in osmotic diarrhea, the presence of these non-absorbable nutrients will drive water from enterocytes into the lumen. So among the examples are functional diarrhea, aka toddler's diarrhea, or people who consume magnesium phosphate or sulfate, as well as carbohydrate malabsorption, lactose intolerance. So special thing about carbohydrate malabsorption is that you can find the presence of such reducing substrate when you do investigation. Next one, we have secretory diarrhea. So this is characterized by active electrolyte and water fluxes towards the intestinal lumen. So in the secretory diarrhea, it's all about secretion. So there will be increase in active secretion. This can be caused by bacterial toxins such as cholera toxins. So if you remember anything about cholera, remember that they have a very high volume of stool. So this is one of the distinguishing features for you to differentiate between secretory diarrhea and osmotic diarrhea. That there's a very high volume of stool in secretory diarrhea, whereas in osmotic diarrhea, the stool volume is only moderately increased. And other causes of secretory diarrhea will include some laxative hormones secreted by certain types of tumors, the active intestinal peptide, or we call as diapioma, or drugs such as penicillin or fluoxetine. And then the third one, we have inflammatory diarrhea. This is caused by immune activation, inappropriate immune activation. causing chronic damage to intestinal epithelium. The usual example of this is IBD. You know that IBD is an autoimmune disease which attacks enterocytes. And celiac disease, I will talk about this more. Infectious disease, reactive colitis, and neoplasia. Last one is fatty diarrhea. We have two, maldigestion, which is defective hydrolysis of triglycerides. This will include pancreatic insufficiency, such as in cystic fibrosis, and bile acid deficiency. And also has malabsorptive syndrome, which is characterized by inadequate mucosal transport. And this will include diseases such as short bowel syndrome and celiac disease. So short bowel syndrome, so what do you think? What kind of baby will have short bowel syndrome? Or what kind of children will have short bowel syndrome? Basically, short bowel syndrome is because of the children has any kind of surgical excision of the intestine. So some patient with malrotation, or one of the more important examples is that patient with history of necrotizing enterocolitis, which most probably will involve surgical excision of the bowel. So this will lead to short bowel syndrome. And when you have short bowel, you have problem with absorption, and this will cause chronic diarrhea. So this is a table to summarize osmotic secretory and inflammatory diarrhea. In terms of stool, osmotic secretory diarrhea will have watery diarrhea, but in osmotic diarrhea you can find reducing substances, and there will be increased osmolarity. So osmotic diarrhea, increased osmolarity, whereas in secretory diarrhea there will be decreased osmolarity. Now, another in inflammatory diarrhea that you can find blood and white blood stool in the stool. One of the distribution features for you to differentiate between osmotic and secretory diarrhea is that we can ask about the response of the patient towards fasting. Right? Please remember this. So in osmotic diarrhea, the diarrhea will stop with fasting. It will improve with fasting. Whereas in secretory diarrhea, no matter how much you fast, the diarrhea will still persist. Right? And in country you can find the exemplary blood mixture and white blood cell. So this is some of other diseases with their own pathophysiology. So I'm going to talk about approach to chronic diarrhea, history, TE, and investigation. So for history, first I want to talk about, I want to ask about the onset. So if the onset of diarrhea is during neonatal period, most probably you're dealing with congenital diarrhea, and congenital diarrhea will involve many syndromes with weird names. It's very rare, but of course, oh yeah, chronic diarrhea is actually in actuality it's very rare compared to acute diarrhea. So yeah, so if you congenital diarrhea is very rare. If the onset is abrupt, you're thinking of infectious diarrhea, especially in cholera, and gradual onset of mild diarrhea, you might be thinking of functional diarrhea. If the diarrhea occurs after introduction of gluten-containing food, then you might be dealing with celiac disease. And if the diarrhea occurs with temporary relationship to eating a specific food, then it might be due to lactose intolerance or food allergies. Now, about the stool characteristics, if you find blood in the stool, then you might be thinking of IBD. If there's bacteria or white light tan color, then you might be dealing with something bile problem, such as bile or celiac disease. And if the stools become looser as the day progress, then you might be dealing with functional diarrhea. Why? Because functional diarrhea is actually because of kids taking a lot of carbonated drinks and all these juices. So as the day progresses, they drink more and more of these these kind of beverages, so that the symptoms becomes more permanent as the day progresses. I will talk about the functional diarrhea later. So other symptoms might include abdominal pain, failure to strive for weight loss. This is very important because it indicates the severity of the problem at hand. So if the patient has failure to strive for weight loss, and then you really have to intervene. But in one thing to note here is that in functional area, it will never ever affect your growth parameters. So if you can also ask about history of recurrent infections. So here you might be dealing with underlying immunodeficiency such as primary immunodeficiency or HIV or cystic fibrosis. It's very rare. And the patient has excessive lactose, then you might be dealing with carbohydrate malabsorption. So for past medical history, you want to ask about any underlying medical conditions such as HIV, immunodeficiency, immunocompromised state, celiac disease, hypothyroidism, because hypothyroidism can also cause diarrhea, and also IBD. And also you want to ask about any previous therapeutic intervention, therapy of drugs, to the colitis, because you know that prolonged ingestion of antibiotics and can cause destruction of the normal flora of the gut. So there will be, things like Clostridium difficile, and this will lead to membrane colitis. Then nutritional history, you want to ask about the breastfeeding history. The exclusive breastfeeding, you know that it can be protective against many types of infections, and this will include internal infections. Formula feeding, you want to ask about the bottle hygiene, the preparation. This is about the hygiene. And then intake of excessive, regarding, you want to ask about the excessive juice, intake of excessive juice, milk or lactose containing food, and so on. So for family history, you want to ask about family history of IBD or celiac disease. And for social history, you want to ask about housing conditions, hygiene, water supply, and sewage disposal. Basically, you want to know about the patient's environment, whether it's clean or not. And that might be because of patient symptom might be because of unclean water supply. So for PE, general examination, one of the very first thing that you want to look at a patient is the growth parameters. You want to plot the growth chart, measure, look for any weight loss, any growth parameter disturbance, because this will shows the severity of the problem. And then because the patient has diarrhea, so you remember that when you're dealing with diarrhea, you always have to assess the hydration status, because patient is losing fluid. So of course, the main reason that patient would die would be because of dehydration. So you need to assess the hydration status. And you can also look for any extraintestinal manifestation of IBD, and it will include symptoms such as arthritis, uveitis, or pyoderma gangrenosum. And then for abdominal examination, you can look for any abdominal distension, abdominal pain, any perianal fistula, intact, and you want to look at the stool. There's any presence of blood, any hyperactive sound of the gut. This might suggest IBD. And don't miss correct examination. You need to perform correct examination to look for rectuma. So investigation, can do full count. You might detect anemia in IBD or any other chronic illnesses. Leukocytosis will be present in infection. In IBD, you can also find thrombocytosis. So you can also order for liver function test. You can find hypoalbuminemia in IBD. And in IBD, you can also find increase in ESR level because it involves inflammation. And RP to assess for hydration status. So you need to also send for stool culture for bacteria, virus study, and so on. Also reducing substances, for this is for osmotic area. globus, lactase, sulfur-acetylene, lactoferrin. This is more to IBD. Then we need to calculate the osmotic gap to differentiate between the osmotic or secreted area. I will show the formula for calculating this later. But as I mentioned earlier, osmotic area will have a high osmotic gap. Osmotic area, osmotic gap. Right. If there's any presence of reducing substance, this will suggest carbohydrate malabsorption. Then we can, if you're suspecting celiac disease, you can do celiac serology. This will include immunoglobulin A antibodies against species transglutaminase. You can also do colonoscopy to localize the area involved in IBD and to get biopsy for diagnosis. And barium follicle can also be done to visualize the small bowel involvement. So this is the formula for osmotic gap. You're going to take 2 times sodium and potassium is 2, and you take the normal serum osmolarity minus the previous 290 minus 2 times sodium plus potassium. So as I mentioned earlier, in osmotic area, there will be high osmotic gap, more than 75 milliosmolar kg, and secreted area will be less than 50. And pH will be less than 6 in osmotic area. Then this is the last part of my presentation. Overview of the common causes of chronic diarrhea. I'm going to talk about 2 diseases: functional diarrhea, celiac, and IBD. The first, functional diarrhea, is the chronic non-specific diarrhea of childhood or toddler diarrhea, diarrhea. So in functional diarrhea, patient will have frequent watery stool, but this is things that I want you to remember. They will have a normal growth and weight gain. Right? Functional diarrhea will not affect your growth parameters. So this is caused by excessive intake of carbonated drinks, sweetened drinks, sweetened juices, because, for example, juices contains sorbitol, which cannot be absorbed by it is poorly absorbed by the gut. So this cause overwhelm the absorptive capacity of the intestine. So as I mentioned earlier, the stool will be progressively looser as the day progresses. Almost all children develop normal bowel pattern at the age of 4 to 5 years old. So the treatment for functional diarrhea is definitely you want to focus on the 4F. But you want to increase 2F, you want to decrease 2F. So you want to increase what you want to increase, what you want to decrease in functional diarrhea. You want to decrease fructose and fluid intake. And the thing that you want to increase is that you want to increase fat and fiber. So basically, it's about a diet modification. In celiac disease, it's gluten sensitive enteropathy. So it is caused by in gluten, you have the main constituent of gluten is gliadin. This gliadin will interact with the patient, interact with the immune system of the patient, and this will cause villus atrophy. So villus, you know that the function of villus is for absorption. So when you have villus atrophy, there will be reduced absorptive capacity. So the symptoms will begin at the age when gluten-containing food are given. So the example of gluten-containing food will be things like bread, barley, cakes, and things like that. Which is commonly at the age of 6 months, we start weaning, or 2 years old. So the presentation, diarrhea, vomiting, failure to thrive, in contrary to functional diarrhea. Irritable, decreased appetite. You can also have flatulence and distended abdomen. Investigation, and you can find anemia, and there's also hypoglycemia. For diagnosis, a serologic marker, anti-gliadin, anti-reticulin, and anti-TTP, tissue transglutaminase. And it also do small bowel biopsy. Here you can find villus atrophy, mucosal inflammation, hyperplasia, and increased number of intraarticular sites. The treatment is basically, you cannot give gluten containing food to this patient if they have severe reaction to it. So it's permanent. It's lifelong. Strict gluten-free diet. And last one is IBD. So this is a very important topic because you're dealing with IBD in almost every posting, right? We discuss IBD in surgery, we discuss IBD in internal medicine, and also we discuss IBD in pediatrics. So IBD, as you all know, it involves many intra-intestinal manifestations, may involve many intestinal manifestations, such as uveitis, acute ulcer, erythema cholangitis, and Crohn's spondylitis. And of course, IBD is divided into Crohn's disease and ulcerative colitis. So we know that Crohn's disease can affect any region of the eye tract from mouth to anus, but it almost always involves the terminal ileum or the proximal colon. So the predominant feature in Crohn's disease involves cramping abdominal pain with diarrhea, usually bloody diarrhea. You can also have systemic signs such as fever, lethargy, retardation, and on examination, you can find abdominal tenderness with mass, most often on the right side, and Crohn's disease is more associated with perianal skin tags or fistula. So investigation, you look for anemia, thrombocytosis. White blood cell can be normal or it can be elevated. There will be hypoalbuminemia, increased ESR because it involves inflammation. In colonoscopy, this is patut pneumonia kan, skip lesion and corpuscle appearance. And barium follicle, you can find narrowing, mucosal and thickened bowel wall. For ulcerative colitis, this almost always involves rectum and will always extend proximally. So presentation, you can have diarrhea, blood mucus tissue, almost the same lah, with disease. But as if I'm not mistaken, in Crohn's disease, the prominent feature is more of the pain, and ulcerative colitis is more of diarrhea. If I'm not mistaken. Investigation, we also find anemia, hypoanemia, the same, rate ESR. In colonoscopy, you'll find diffuse suppression of distal on the entire colon with loss of postural folds and tiny ulcers. And then there's no skip lesion in ulcerative colitis. Whereas in Crohn's disease, you can find skip lesion in it. The histology, you can find cystitis, abscess, rectal ulcer. Management, since this is an autoimmune disease, so almost more often than not, in autoimmune disease, you can treat it with steroids. So you can give oral prednisolone, 5-ASA, immunomodulators such as azathioprine, and if it's refractive to medical therapy, and you might have to resort to colectomy or bowel resection. In Crohn's disease, as an addition, you can do some diet modification with polymeric diet. So polymeric diet is actually when you have a diet consists of whole protein, but none of the protein has been broken down into smaller constituents. So this among the examples we ensure Astrocal, the brand name. So yes, and this is a table differentiating Crohn's disease and ulcerative colitis. So rectal bleeding is more common in ulcerative colitis, whereas abdominal mass, perianal disease, transmural involvement, friction, fistula, skip lesion, you're gonna find it more in Crohn's disease. So I guess that's all from me. These are my references. If there's any questions, you can ask me. On the floor.
Okay, good. Okay, good presentation. Any question?
I have one question. It's not really a question. I want to, so can you repeat the management, the 4F management in the functional diarrhea?
Oh yeah. 4F, you wanna decrease 2F, which is fructose and fluids. You wanna decrease fructose and fluid intake, and you wanna increase fat and fiber. That's 4F. Any other questions?
in general, basically any functional diarrhea, things like IBS, for example, IBS with predominant diarrhea, the management, any functional usually just by nutritional therapy lah. Basically, you just increase the fat and also fiber. Fiber for bulking agent and fat for actually for solidify your stool lah. Actually, if you notice, if you eat a lot of fat, you become constipation. So in order to treat functional diarrhea, you just constipate yourself by fat lah, by eating fat. And then reduce water and also fructose is quite straightforward lah, because the pathology is actually functional diarrhea is actually osmotic diarrhea. Most of the time it's actually osmotic kind of diarrhea. So by reducing carbohydrate, especially this complex carbohydrate, then you usually improve the symptoms.
Any other questions? If there's none, I'm interested with the next.
Actually, I've got a few comments. I mean, chronic diarrhea usually we define as more than 2 weeks, kan? But some resource say like 2 to 4 weeks is considered persistent diarrhea. More than 4 weeks only you can say is a chronic diarrhea. But that doesn't matter lah. That's not really matter much clinically. And then in your slides, I think you divide the causes of diarrhea. I'm not sure which slides. Further up. Okay, yeah, that one. With a boy. With a BO boy. Next. No, lower down. I think it's like number, yeah, this one, number 10. So actually, and from the initial presentation, you mentioned quite, I mean, the presentation is quite good, where you actually classified the diarrhea according to the pathology. So whenever in medical, you have to look sleek and you have to look quite systematic, especially in presenting your differential diagnosis or your thinking. So ideally, whenever you present a differential diagnosis, you have to present it in a systemic way. For example, you can divide them into etiology. You know, like I used to mention, you know, vitamin A, B, C, D. This is what we used to use lah, the vitamin A, B, C, D, E, K. So these are dividing, I mean, formulating your differential according to etiologies, kan? So for example, you can say like vascular causes. You know, some vascular causes can actually cause diarrhea, especially lymphatic problems lah, chronic lymphatic punya problems, especially congenital lymphatic abnormality, they can sometimes presented with diarrhea. So vascular, and then vitamin, kan? I is infectious. Okay, some infectious. For example, which is very common in Pahang. I think one of the commonest, one of the state with the commonest incidence is actually typhoid, kan? Typhoid is very common in Pahang and in Kelantan, especially in Kelantan lah, typhoid. Melioidosis can also sometimes present with diarrhea. And these are actually chronic infections, so they can present for long period. And then hepatitis A can also present with diarrhea, chronic diarrhea. A and E lah especially. And then you can divide, you know, etiology, vitamin A, B, C, D, E, K, things like that. You can also divide by site, kan? By site, for example, pathology at the small bowel, pathology at the large bowel, pathology at the upper up at the GI tract, maybe at the duodenum or even higher up at the gastric level, kan? Because you know AGE as the name explain is acute gastroenteritis. So it's actually inflammation at the gastric and also at the small bowel. So the pathology of AGE is actually at the above the small bowel lah. So that's why. So when you divide into sites, kan? When you divide into sites, it's easier. You can categorize the stool into I mean, you can categorize the diarrhea into its nature, you know, the osmotic type or the secretory type. For example, pathology at the large bowel, what do you expect it will be? So if someone got pathology at large bowel, for example, colitis kan, colitis such as cholera lah, cholera is a colitis, cholera or Crohn's disease kan, Crohn's disease, ulcerative colitis as the name describe lah. So what do you expect the stool will be? If you got a pathology at large bowel, anyone can answer, can guess maybe what type of stool you have? Okay, okay, it's loose stool. Okay. Besides that, what's differentiate pathology at the large bowel and pathology at the small bowel? How the stool looks like?
If it's large, it's more well formed, so maybe mixed or like less watery, not watery, unlike at the from the small bowel.
Okay. Actually, it's the vice versa, because the role of large bowel is for water absorption, isn't it? So if you've got pathology at at large bowel, you will produce large amount of fluid, large amount of stool. That's why in cholera, because the the infection, the toxin is actually at the large bowel, so the patient lose the capability of reabsorption. So they lost a lot of water. They died because of dehydration in cholera. Okay, then they don't really die because of sepsis. They die because of severe dehydration. But in, for example, in small bowel pathology, for example, in AGE, right? AGE, rarely, I mean, a typical AGE, they rarely presented with dehydration. Okay, unless if they got the symptom for 2-3 days. Okay, because the main pathology is actually at the small bowel. Okay, you know, the small bowel, the role is actually for digestion, kan? So there's a lot of enzymes, there's a lot of, you know, this hormone, paracrine hormone. So there's a lot of inflammation. So most of the time it's actually inflammatory diarrhea or and secretory diarrhea lah and also osmotic diarrhea in small bowel. Because when the problem is there, so there will be problem with maldigestion, malabsorption. So they prone to get, you know, this osmotic problem, osmotic diarrhea, and also inflammatory diarrhea. So in AGE, sometimes you've got blood. The stool is actually not that much. The amount is not that much, but it's very irritating. So you've got nappy rash, and you got excoriation because of the irritation from the stool. Low pH stool, kan? The pH, the stool is acidic. The smell is acidic. Macam tu lah. Okay, faham kan? So you can divide into etiology, into the site or age, kan? You can divide. Chronic diarrhea can be divided into age of presentation. Okay, in neonates with diarrhea is most of the time, especially when they start feeding, most of the time is caused by metabolic causes, not genetic or metabolic causes. Either genetic abnormality, anatomical or structural abnormality, or metabolic problems. I've seen one baby, actually not, I think he's already, I'm not sure if she's still alive. I think she's already like 8 or 9. She's on lifelong TPN because she's got I think lactase deficiency, I think something like that. Galactose deficiency, something like that. So because of genetic metabolic condition leads to deficiency in specific enzyme, so she cannot digest any carbohydrate. So she's been in hospital in for the first 4 years of life, and then she was discharged, I think, at the age of 5 or 6 years old with home TPN. I'm not sure whether she's still alive, but because she's quite well, as long as she's got the TPN, she's well, but she cannot eat anything that contain carbohydrate cannot be eaten. So usually congenital, most of it is genetic or metabolicnya tinggi lah. And then maybe you can add, for those like age toddlers or young toddlers and infants, they can have, you know, functional diarrhea because of like you mentioned, like the chronic congenital functional diarrhea, kan? And then kalau older, maybe at the age of like 10 to 12, 11, they may present. I mean, IBD is usually present at this age, IBD, especially Crohn's disease. Contoh, and then pathology, you can also divide into pathology. Because for example, look at the slides kan. Like functional diarrhea, factitious diarrhea, this can be categorized into, like maybe by pathology. So these are actually osmotic diarrhea. Or by etiology, vitamin A, B, C, E, D. Okay, itulah. Okay, and then on history, the most important is actually to find the red flag, to ask about the red flags symptoms. Similar to adult kan, similar to adult, you ask about the red flags kan. Any adults presented with lower GI problems, even upper GI macam dyspepsia ke, you have to ask about the red flags kan. What are the red flags? Okay, anyone? What are red flag symptoms in chronic diarrhea?
Constitutional symptoms.
Okay, constitutional symptoms such as lost weight.
Loss of weight, loss of appetite.
Lagi?
Symptom of signs of diarrhea because it's associated with high mortality. Of diarrhea, sorry, of dehydration.
Okay, usually chronic diarrhea, they don't have dehydration because if they have dehydration, they presented earlier, they won't have chronic diarrhea. Because rarely they've got dehydration. Because dehydration usually not an issue. But if they got dehydration, then it'll be difficult lah. The red flags, macam dah adult kan?
Rectal bleed.
Rectal bleed, lagi hematemesis, lagi mass kan? You rasa mass. And then ascites. These are the things that you have to ask lah. Ask and examine. Because usually the patient with chronic problems, especially chronic diarrhea, if they don't have any red flags, you can actually give them reassurance, discharge, and you can do further investigation. Okay, you don't have to rush. Okay, as long as they don't have red flags, you don't have to rush. So actually most of chronic condition, anything chronic, we don't talk about acute lah, chronic respiratory problem, chronic neurological problem, anything that is chronic, the more chronic it is, the more time you can take, as long as there's no any red flags symptoms. So for example like cardio kan, patient datang dengan chronic palpitation, dah datang dah, atau chronic chest pain, dah datang, dia tanya history, oh dah sebulan dah macam ni. So you can actually take times. You can take times. Okay. It's not that you don't have to rush. I mean, it's not like takes time. If you can get the diagnosis earlier, then you manage earlier, you treat earlier lah. Tapi if you need to take time, you can, as long as there's no red flag symptoms. Okay. Okay. And then water supply is very important, especially at this region of Malaysia kan, the southeast, at the eastern region. Water supply is very important, especially kalau you pergi Kelantan, you kena tanya lah guna boring ke, because this is the source of infection. Okay, ask about Pika pun you kena tanya, especially kalau you come across orang asli ke, atau those, even Pika is quite common lah. Pika is very common. Worm infestation kan. And then okay, last sekali I nak tanya, so how do you diagnose lactose intolerance? Patient presented with chronic history of flatulence, bloatedness, diarrhea, annoying. They usually call it as annoying diarrhea because it's not a massive diarrhea, but it's annoying because it's a spurting of diarrhea and come with a flatulence. So how do you actually diagnose diarrhea? You did mention a bit.
Yeah, so
Okay, how do you diagnose lactose?
for the presence of anti-glycine, anti-PTG.
That is actually celiac kan? That is celiac.
You can try trial of free lactose diet
Okay.
and then breath hydrogen test.
Hydrogen breath test kan? Okay, that's the gold standard lah. Is hydrogen breath test is the gold standard. So hydrogen breath test you kena buat ni lah. You kena buat OGDS. Okay, you need to do OGDS. So the gold standard, kalau in exam, how to diagnose lactose intolerance, the gold standard is hydrogen breath test. Okay, it's not stool reducing sugar. Okay, backside kita buat stool reducing sugar in what? Tapi the gold standard is actually lactose intolerance. And if you want to take sample for stool reducing sugar, how do you take the sample? Which part of the stool you kena send for investigation? Is it the particles or is it the fluid or is it the mucus? Is it the blood? Kalau ada blood lah. Anyone? Okay, so basically, to send for stool reducing sugar, you have to take the water part. So if the child is actually on diapers, what we do is usually we turn the diapers upside down. So upside down. How to say? The plastic part of the diapers, the external part of the diapers kan, inside out. So you turn the diapers so that the water will actually accumulate, which actually like pool in the diapers. Because if you use the diapers, all the water part will be absorbed by the spongy part of the diapers kan. So you can turn it upside down, inside out, so that you can collect the water. The water of the stool that you send for stool reducing sugar. Okay kan? Okay, got any question ke? Okay, any question?
No.
Okay, so the place where I train, we've got more chronic diarrhea lah. We've got a lot of celiac. Celiac disease is very common. And then CF, cystic fibrosis, is also quite common. In Malaysia, actually, it's not that common lah, chronic diarrhea. You see IBD on and off, but most of the time, it's functional lah. Okay, next slides. Next presentation.
Assalamualaikum. Everyone can see my slide? Yes.
Yes.
My name is Nurul Farhana, so I'll be presenting on chronic constipation in children. All right, this is my overview. So firstly, I'll talk about the definition of constipation I got from Nelson Essentials. So this is where there is less than 2 stools per week with passage of hard, pellet-like stools for at least 2 weeks. So it's basically the passage, infrequent passage of dry and hardened feces with straining or pain and associated with hard stools. So this is the Bristol stool chart, which we use to classify the type of feces. So the ones that we're concerned with is type 1 and type 2, which is involved in constipation. So the causes of constipation, there's either functional constipation or organic constipation. So the most common cause is functional constipation, which involves more than 95% of cases, while organic constipation is just less than 5%. So functional constipation usually occurs in preschool years, while organic constipation, we diagnose them during infancy. So functional constipation, they have at least 2 of the 6 criteria, which describes the stool frequency, hardness, size, fecal incontinence, or volitional stool retention. This is included in the Rome 4 criteria. So for the organic constipation, the causes are from anatomical causes, intestinal causes, drugs, metabolic disorders, and intestinal disorders. So these are the common causes. So the first one is functional constipation. The next one is Hirschsprung disease. And then there's anorectal malformation, systemic illnesses such as hypothyroidism and spinal cord anomalies. And the next one is drugs. So this is a table on the other causes of constipation. So first one is functional constipation. So the next one is developmental disorders such as behavioral disorders, ADHD, and autism. So about developmental disabilities, they are high risk for constipation because they have a reduced capacity to tolerate, cooperate with toileting, and there is a reduced effort or control of pelvic floor muscles during defecation, and they sometimes don't realize the need, they have the urge to pass stool, all right? So the other ones are like occasional constipation, forced toilet training, phobia, sexual abuse, psychological causes, and the other organic causes listed here, all right? So the common cause, which was functional constipation. So I already explained the definition earlier. So let's go to the pathophysiology. So in functional constipation, the child is unwilling to defecate in the toilet and the retained stool becomes harder. So there's painful defecation, which leads to more voluntary withholding and more constipation. So the risk factors are usually low fiber diet with a decrease in fluid intake and also anxiety because the child is afraid to defecate. So because of the pain, and also some children don't like going to the toilet in unfamiliar places, for example. So the clinical features are retentive posturing. So you can see on the photo on the left lower side, the children there, they try to control, they don't want to defecate at the time, so they have retentive posturing. So other clinical features such as fecal incontinence due to leakage of retained stools called encopresis. So this is usually in chronic constipation where the rectum becomes over-distended with loss of feeling the need to defecate. So involuntary soiling may occur, which because of the contractions of a full rectum, which inhibit the internal sphincter, leading to, all right? So in the physical examination, usually functional constipation patients have a normal physical examination, but some may have a reduced sphincter tone or a dilated rectal vault, rectal impaction, soil underwear, or palpable fecal mass in left lower quadrant. And those who we suspect with functional constipation, usually we don't really do any lab investigation unless we suspect that the cause is organic. So unless we do an investigation, most likely we'll see a dilated bowel because of the impacted feces. All right, so this is what I explained earlier. Because of the painful defecation, the child has voluntary withholding, which causes more constipation and more pain. So the cycle will continue because the risk factors, which I explained earlier, because of a change of diet, a stressful event, postponing defecation, all right? So this is the criteria. Most of the things I already mentioned earlier, all right? So there's infants and toddlers for up to 4 years old, and the other one is for children and adolescents for more than 4 years old, all right? So the next one is Hirschsprung disease, all right? So Hirschsprung disease, there's a failure of ganglion cells to migrate into the distant bowel. So it leads to spasm, functional obstruction of the aganglionic segment. I'll explain about it more in the next slide. So for the history of Hirschsprung disease, since this is an organic cause of constipation, we'll diagnose it very earlier on when there's a delayed meconium passage around 24 to 48 hours, which is the normal time in which a neonate should pass out meconium. So what we're looking for in the patient is abdominal distension, bilious vomiting, fever, foul-smelling stool. So this is usually because of Hirschsprung enterocolitis, or the children in later childhood will have chronic constipation with abdominal distension, and usually there's no soiling and there can be growth failure. So in physical examination, there can be a narrow segment or a tight anal sphincter during digital rectal examination, and there can be an explosive release of the stool as the examiner's finger is withdrawn. All right. Okay, so for the next slide, I'll be talking about the pathophysiology. So what happens in Hirschsprung disease, there's the neural crest cells. They actually migrate from the mouth to the anus during developmental period, about week 8 to week 12. So when their journey is disrupted, it can cause there to be Hirschsprung disease. So because there is absence of ganglion at the submucosal plexus, the Auerbach and mesenteric plexus. All right. So what happens is that there's disruption of migration, and the nerve fibers don't develop in some parts of the colon and the rectum. So when there's no nerves, there's usually inadequate peristalsis, and the muscles will stay contracted. All right. So when the muscles stay contracted at the distal aganglionic part of that rectum, it will cause there to be blockage due to feces collection, and then because of this, there will be a dilation of the colon, which is megacolon, and then there can be constipation, and also it can lead to bowel obstruction, and there's a risk of rupture, and also there's risk of enterocolitis and chronic constipation. All right, so for Hirschsprung disease, how we investigate the child, we do the gold standard, which is suction rectal biopsy. So for suction rectal biopsy, we have to get the mucosa and the submucosa, since the plexus are on the submucosal level. So the next one is barium enema. So this one, we can look for the transition zone between the narrow aganglionic distal bowel and the proximal distended normal bowel. All right. So for the treatment, it's usually surgical. Once we've diagnosed it, we have to remove the part that is aganglionic and do a colostomy, and then we have to anastomose it back to the normally innervated bowel to the anus. All right. So the photo above is the barium enema. All right. This one shows the aganglionic segment. All right. And the bottom photo is for the colostomy. All right. Okay, so approach to chronic constipation, just like any other symptom, we have to approach it this way. So firstly, we need to find out whether it's functional or is it organic constipation and the onset. So these are all found out during the history, all right? So for history taking, I mentioned earlier, for Hirschsprung disease, we find it early on because of no passage of meconium around 24 to 48 hours of life. And also, for functional constipation here, the risk factors I explained earlier, any diet change, or was it during toilet training, or was the child having any fear or anxiety of going to the toilet? And for the stool quality and appearance, so we have to ask whether there was painful defecation, whether there was blood in the stool, because most likely, because of the hard stool in constipation, the child can get an anal fissure, and the anal fissure causes a lot of pain, so the child doesn't want to defecate, all right? And then for the consistency of the stools, whether it's hard, pellet-like, most likely it's functional constipation. And were there any accidents because of the defecation? For example, like the fecal incontinence. So the child will feel embarrassed to BO. So for diet history, ask whether there's adequate source of fiber and adequate fluid intake, because this can contribute to constipation. Any change of diet, for example, using cow's milk, possibly cow's milk protein intolerance. And then were there any underlying medical problems to find an organic cause, such as congenital anomalies, abnormal growth, or developmental delay. So for example, Hirschsprung disease is common in Down syndrome children, and also some children with congenital malformations such as kidney and urinary tract anomalies. They can have anorectal, sacral, and also spinal abnormalities, which can interfere with their defecation. So these are the red flag symptoms or signs that you need to find in case a child has constipation. So most of these have already been explained in this slide earlier. Alright, so most of these symptoms have already been explained in the slide earlier. This is mostly to find the organic cause of constipation because we don't want to find it too late because it'd be detrimental for the health of the child. So the physical examination, firstly we find the build, we look at the build of the child, whether he's thinly built, whether there's failure to thrive or there's nutritional deficiency, and whether there's dysmorphism such as Down syndrome. So also see if the child has fever or is dehydrated, if the child is in retentive posture with lower limb abnormalities, hypotonia, and atrophy. All right, so physical examination for the abdomen, see whether there's a palpable stool mass or a mass in the suprapubic area. Most likely there's a rectal stool infection. So for the spinal cause, look for whether there's any cutaneous change in the lumbosacral area, a dimple, a hair tuft, lipoma, or any deviation of the gluteal cleft. Look for the soiled underwear. So this is in the presence of rectal stool infection, can suggest overflow incontinence. And this is, the next one is absence of anal wing, which suggests neurological deficiency. And the next one is anal fissure scarring and anteriorly displaced anus or perianal fistula. Right, so these are the photos of the conditions I talked about earlier, such as spina bifida, anal fissure. This is anal reflex, also known as the anal wink. So you stroke the skin surrounding the anus to see whether there is a reflexive contraction. And the photo below is for fistula. All right, so for the DRE, digital rectal examination, check for the tone, the size of the bowel, see whether there's impacted stool or explosive expulsion of stool after examination. So for investigations, since I said earlier that if it's functional constipation, usually we don't investigate, but if we suspect it's like an organic cause, then we can do blood investigation, imaging, and rectal biopsy. This is to rule out whether it's hypothyroidism, whether there's an electrolyte disorder or IBD. So for the imaging, like barium enema to rule out Hirschsprung disease, and the spine radiograph to rule out any spinal abnormalities, and rectal biopsy for Hirschsprung disease. So for the management and also maintenance, firstly, the most important thing actually is the second point, to evacuate overloaded rectum with either enemas or laxatives. So we can give an osmotic laxative, such as lactulose or PEG, or a stimulant laxative, such as bisocanol. And for the next point is toilet training and to avoid voluntary withholding. So how we do this is that, like in the morning, when the child wakes up, we can ask the child to sit on the toilet for a few minutes, or immediately after meals when the colon is most active and it's most easy to pass stool. This is because of the gastrocolic reflex, which is a physiological reflex that controls the motility of the lower gastrointestinal tract following a meal. So basically, it's like rest and digest. So during this time, you're more likely to defecate, right? So because of this, there's an increase in motility in response to the stretch of the stomach with the ingestion of food. And the next one is positive reinforcement. For example, like a star chart. For example, like, oh, you defecated today, so put a star there. Congratulations. Just keep encouraging them to, defecate. And the third point is dietary interventions, such as a balanced diet, whole grains, fruits, and vegetables, and make sure that the patient has sufficient fluid. All right, so this is what I explained earlier about how we manage and maintain it. So first, ensure adequate oral fluid intake and good toileting habits. And then if there's an infection or a mild constipation, we'd like to treat it with laxatives, or we can give osmotic laxatives, stimulant laxatives, and increase the dose and reduce the dose, and to maintain, to ensure that the child keeps on defecating. All right, so that's all from me. Thank you.
Okay, good. So chronic constipation is most of the time is functional constipation in pediatric. So again, I would like to stress on identifying the red flags, and if there's no red flags, then chances are these are functional. Any questions from the floor?
I have a question. Just now, Farhana mentioned about the duration of laxative. May I ask, is there any like a maximum duration that we can use laxative because the patient might be dependent on it?
All right. Okay. All right. So I understand with the use of laxatives, I know that there can be lazy bowel syndrome, but honestly, I don't really know how long it'll take for you to develop that syndrome. But I do, from my reading, they said that we usually underuse laxatives. So I think I don't really know the correct duration.
So in general, management of chronic constipation, you divide into two. First is the stool disinfection, okay, either medically or surgically or mechanically. And then after stool disinfection, usually takes about up to 1 week. And then you maintain, okay, maintain usually up to 6 months. And the type of, the choice of laxative, actually the osmotic laxative, I think osmotic laxative is actually okay. I mean, there's no, to the best of my knowledge, it actually doesn't cause any much harm, especially in the development of lazy bowel syndrome. However, okay, stimulant laxative is actually has to be used in cautious. Okay, usually when you are doing stool disinfection, we start with mechanical, okay, by fingering. I mean, you remove the hard stool near the anus first, the rectum. Okay, remove them mechanically, or if cannot, then you can use surgical removal by surgeon lah. Not necessarily dissection, but they have their own way to do it lah. And then you sometimes you need a stimulant. Okay, the most common stimulant that we use is bisacodyl, because we don't have Senocot is not that available, readily available in Malaysia, but Senocot is a better option than bisacodyl in pediatric. However, okay, prolonged use of you just use it for the first initial part of stool disinfection. Okay, the stimulant. The rest you use lactulose or pack. But usually lactose and pack lah. We rarely use, especially in pediatric, we rarely use paraffin oil, organic oil, because the risk of aspiration lah. Especially those yang with underlying neurological problems or respiratory problems, we don't give them organic mineral oil because it can lead to pneumonitis. Okay, so so you just use short duration of stimulant, because if you use longer duration, then you can develop lazy bowel syndrome or toxic megacolon. Usually, the last stage is actually toxic megacolon. Okay, so that's really. Any more questions? Other questions?
No.
Okay, I want to add a bit about Hirschsprung. Okay, Hirschsprung now, I mean, the recent evidence found that Hirschsprung is actually a continuum. Okay, it's not a Hirschsprung. You've got Hirschsprung or no Hirschsprung. Actually, Hirschsprung disease, you've got different categories of Hirschsprungs. You've got the ultra short segmental Hirschsprung, you've got segmental Hirschsprung, short segmental Hirschsprung, or you've got extensive Hirschsprung. Okay, usually those that is detected early on in neonatal period, those with extensive Hirschsprung or short segmental Hirschsprung. But there are also Hirschsprung that is diagnosed in adulthood. These are actually the ultra short segmental Hirschsprung. Okay, you have to understand the development of your parasympathetic nervous system of your GI lah. Okay, because you know the bowel movement is actually controlled by your parasympathetic kan. which they have got the ganglion, the submucosal parasympathetic ganglion. So this ganglion actually develop proximally and it grows to distally. Okay, that's why by term, it's only by term you will start to have fully developed ganglion at the sphincter level. At the distal level, it's only developed at term. That's why you don't diagnose Hirschsprung in prem baby. You don't diagnose Hirschsprung in prem baby. You wait until they become full term, the corrected gestational age 40 weeks. If they persist, I mean, if you did rectal biopsy and persistence of a ganglionic at the distal area, distal rectum, then only you can label this child as a Hirschsprung. To have Hirschsprung. If prem baby, you did biopsy and there's no, that's why we don't do biopsy, rectal biopsy in prem baby, because most of the time they don't have ganglion at distally. So usually, I think there are few case reports, or I think some people say they are actually skip lesion in Hirschsprung. So for example, they may have normal ganglion at distal, but they proximally they don't have ganglion. But this is actually, we are not considering this is Hirschsprung, because Hirschsprung has to begin from, I mean, the disease has to begin distally. So with ultra short segmental Hirschsprung, they have, I mean, they don't have ganglion exactly at the distal end, the far distant, very short segmented. So these people, they grow up normally. I mean, they've got constipation throughout their whole life, and usually until after constipation is developed, they pass BO within 24 hours of life, but later on they start to develop toxic megacolon at the age of maybe 30, 40, even 40 years old. There are people with presented with toxic megacolon and then diagnosed as Hirschsprung at 40 years old because of this ultra short segmental Hirschsprung. So remember, Hirschsprung is a disease of term baby. You don't label preterm baby with Hirschsprung because they, by default, they don't have the distal ganglion unless until they term. And this is why preterm baby should not develop meconium stain liquor in uterus. Okay, from that, if a preterm baby they've got meconium stain liquor, it has to be infectious causes. Most of the time it's listeriosis, okay, or something else, because they are not supposed to BO because they are prem. Okay kan? So cukup about Hirschsprung. Any more questions?
Sorry, Doctor, I would like to ask, is there any, for constipation in pediatric cases, is there any association with complicated like hemorrhoids?
Yes. You do see hemorrhoids in pediatric, but usually the older children lah.
The older children.
But you do see hemorrhoids in pediatric, but actually kan, constipation is not really benign as you think it is. Okay, it's not really benign. Because chronic constipation can lead to terms that we call dysfunctional voiders. Dysfunctional voiders. These children, because the chronic constipation can lead to recurrent UTI, and a lot of time because this is habitual, so they have both. They restrain themselves from PU and also BO, so they end up develop VUR, recurrent UTI, and a lot of them actually develop CKD. We've got few patients. Actually, I've got one patient back in USM. The child came with secondary aneurysm, okay, and chronic functional constipation. At the age of, I think, 13 years old, came to us at the age of 13 years old, and this guy is actually the child, the son of, his mother is actually a very senior pediatrician, neonatologist, very senior neonatologist. The mother is a very senior neonatologist, and the child is actually referred to us, and the child got CKD stage 3 on by the time of reference lah. because it's just simply dysfunctional borders. So they move to school. Social is very important. A lot of time, the onset of the problems have to be determined, because a lot of time these children, they develop these problems after they move school, or they move to new school, they move to new house, or the father remarried, the mother remarried, they've got step sisters, step brothers. These have to be explored. Okay. For example, they just renovate the house. Previously they use the squatting toilet, now they use the sitting toilet. Things like this is important. Okay, because constipation is not without a risk. Okay, anything else?
Doctor, I have question.
Hmm.
You mentioned earlier that one of the mechanical procedure is fingering.
Oh.
But I want to ask, I thought it was the digital that the examination should not be performed in child. Is it different, the extent of fingering and also the digital?
Actually, we rarely do PE, as you mentioned. We rarely do PR lah in pediatric. Okay, because a lot of time, if you palpate the abdomen, there's a impacted stool. You can feel the hard mass there. You can confirm the diagnosis of this is a constipation. You don't need to do PR lah, unless if you suspect something yang organic, especially the spinal problem, problem with innervation, spinal bifida, neurogenic bladder, those especially with with concomitant neurogenic bladder kan. Tapi fingering, what I mean with fingering is patient with chronic constipation and stool infection. The first step to this impact is you need to remove the most distal obstruction, because if you give patient lactulose without removing the obstruction, because it is too big, okay, if the stool is massive at near the at the rectum, and then you give lactulose, the proximal stool will keep on pushing and patient will vomit. Okay, they can even develop obstruction, IO. So you have to at least most of the time we use finger to actually remove part of the massive stool. Okay, I'm not sure whether you've seen children passing out. I mean, constipated children passing out motion, but it's similar. It's similar to giving birth. Similar. I've got actually 2 of my children got problem with constipation, and they are actually giving birth. So it's very painful. So you need to, I mean, cut it into like pieces, remove it mechanically, then only you start use stool disinfection, medical stool disinfection using lactulose lah usually. Okay, the best is pack, tapi pack not easily available lah, so use lactulose lah. And the dose is, we call it ultra high dose, which is usually the usual dose is about 0.5 ml per kilo, but you can give up to 2 ml per kilo for disinfection. Give for about 1 week until the child passed out massive like hard stool, massive hard stool. Then only you maintain for usually 3 to 6 months. Okay.
Okay, get there.
Okay, good. Next presentation. Hopefully by 11 lah latest kita kena stop. So this is exhausting. Okay.
All right. Okay. Assalamualaikum warahmatullahi wabarakatuh. Can everyone see the screen? See the presentation?
Yeah, but it's not in the presentation.
About now? Okay. All right. Thank you. Okay. Assalamualaikum warahmatullahi wabarakatuh. My name is Muhammad Jazli. I'll be presenting about liver failure in children. So the topic of liver failure in children is rather similar to what we learn in internal medicine, but there are a few differences in terms of how we approach, and the differentials that we need to consider in cases of pediatric. So first and foremost, we need to know that it is divided into acute liver failure and chronic liver failure, but the definition is also different to some extent. So in acute liver failure in children, it is defined as evidence of acute liver injury with no known evidence, with no known evidence of chronic liver disease. Apart from that, it needs to come with, can come with biochemical or clinical evidence of severe liver dysfunction. And this evidence by prothrombin time, which is more than 20 seconds, or INR, which is 2 or more, and that is not corrected by parenteral vitamin K, a routine management we give upon a newborn. And or evidence of hepatic encephalopathy, which must be present if the PT is 15 to 99.9. Okay, so this is based from the pediatric protocol. So this one is really important for us to know as a definition. Apart from that, in sunflower, they define it as a form of severe liver disease with onset of hepatic encephalopathy within 8 weeks from initial symptoms and with the exclusion of the CLD. Okay, right. So these are varieties of the definition given from the different textbook. So based on Nelson, they divide this liver failure in child in terms of metabolic, cardiovascular, infectious cause, neoplastic, toxic, and immunologic. So roughly we have 6 in total. So as you can see that metabolic is quite important differential to consider, especially in cases of neonates. In terms of the how frequent it is, you can see that neonates, it tends to be more frequent to have infections, and then you can also have metabolic, which is rather more frequent compared to the adults, which tak ada kan. And then you can have rare cases of ischemia or toxin and drugs. So moving on to our first etiology. So the first etiology we would like to consider is iatrogenic cause, which is toxic cause. There are many causes that can cause acute liver failure in children. And the drugs that could cause include things such as paracetamol overdose, hepatotoxic drugs such as antiepileptic drug, phenytoin, sodium valproate, carbamazepine, lamotrigine, and antibiotic will include erythromycin, quinolone, isoniazid, and tetracycline. Okay. So I would like to share something about there's a case that clinical case that I had the opportunity to see in HKL, a mortality case whereby boy aged around 5 months presented with loss of consciousness. So basically he was apparently well and he got some fever, and the mother was like from foreign nationality, not really familiar with the medication. So she bought a lot of this paracetamol, and due to the concern, she kept in giving the child the paracetamol until the child died due to paracetamol overdose. So in such cases, what needed to be done? So in such cases, in a case of paracetamol overdose, what can be done in the first management wise? First, you have to resuscitation. Afterwards, if the ingestion of the paracetamol is within if it's within 1 hour of ingestion, you can consider giving activated charcoal. Okay, if it's within 1 hour of activation. If it's more than that, the management does not play a significant role, and you can give NAC and acetyl NAC. NAC. Because this NAC, they could help to reduce the effect of the paracetamol overdose. And the threshold of giving NAC should be very low. Why? Because there is a low side effect from the NAC. So in the case whereby you suspect the patient could have paracetamol overdose, it should be given. Apart from that, you should monitor with serum acetaminophen to see the progress, as that would affect how much NAC you want to give for the patient for the management of paracetamol overdose. Yeah. So moving on to the different causes. So just now was toxic cause. Now we move on into the metabolic cause. The metabolic cause will include things such as inborn error of metabolism. And inborn error of metabolism would include things like urea cycle defect, galactosemia, and tyrosinemia. Okay, urea cycle defect is basically a deficiency of enzyme in the pathway of urea cycle, and it is associated with immaturity of the neonatal liver. Okay, it's associated with immaturity of the neonatal liver. And it is, the way we investigate is that we assess amount of serum amino acid. It's supposed to be elevated in case of urea cycle defect. We treat this case with, we can consider giving dialysis to return to normal ammonia level. Apart from that, you can have galactosemia, which is carbohydrate metabolism disorder. We investigate using galactose to see whether the investigate for galactose 1-phosphate uridyl transferase to see the amount, whether it is elevated or not in such cases. And the management include reducing the amount. So roughly the concept of inborn error of metabolism, we need to identify which one is elevated and what we need to reduce in order to mitigate the effects. Apart from that, you can have also things like Wilson disease, which is an autosomal recessive disorder affecting chromosome 13. Yeah? Autosomal recessive disorder affecting chromosome 13. For the treatment-wise, you can give penicillamine. You investigate for serum copper, ceruloplasmin, and 24-hour urine copper, because that's one of the cause. The cause is elevated copper. And you can have neonatal hemochromatosis. Neonatal hemochromatosis is basically a severe liver disease in the newborn, accompanied with extrahepatic cirrhosis. So what investigation you would do serum ferritin and lip biopsy. By meaning of lip biopsy, basically you take a portion of the salivary gland at the lip, because that's where you can see evidence of the elevated cirrhosis. Because as mentioned, neonatal hemochromatosis is severe liver disease with accompanying extrahepatic cirrhosis. Okay, so this is just roughly about galactosemia just now. So you can see that one of the enzyme included is this, and it is defective in this form of inborn error of metabolism. Okay, cardiovascular. For cardiovascular cause, it can be due to shock or hypertension, and it can be due to Budd-Chiari syndrome. So what is, I think shock and hypertension is people are familiar, but basically what happens is that you have hyperperfusion of the liver, and then it can cause the liver failure. But Budd-Chiari syndrome basically is an uncommon condition induced by thrombotic or non-thrombotic obstruction of the hepatic venous outflow. Okay, non-thrombotic or thrombotic obstruction of the hepatic venous outflow, and is characterized by evidence of hepatomegaly, ascites, and abdominal pain. The most common form of this Budd-Chiari syndrome, because they have many forms, but the most common form is the chronic form, where patient presented with ascites, jaundice, and approximately about 50% of them have renal impairment. Okay, so if you see this image, you can see that in Budd-Chiari syndrome, there is a defect in the hepatic vein, and at least it is diagnosed when there is occlusion of at least two or more of the hepatic vein, and this causes the retention of all the substance, and it can cause the pathology of the Budd-Chiari syndrome. Commonly associated in cases that associated with thrombosis, such as pregnancy or cancer. Apart from that, you have malignancy cause such as leukemia and lymphoma. Because of the leukemia, lymphoma, you can have all these infiltrations, and because of the infiltration, it can cause liver failure. And apart from that, even secondary metastasis can cause also the acute liver failure. Autoimmune hepatitis is basically you have autoimmune which attacks the liver. But there are mainly two types. There are type 1. There are type 1 and type 2 autoimmune hepatitis. The differences basically in the investigation you would like to do. In type 1, you can do things such as ANA, search for asthma. These are the characteristic autoantibodies, which is different from type 2, which is associated with anti-LKM1 antibody, anti-LC1 antibody. The features is rather similar. The female is 3:1, but type 2 is more prevalent in female, which is 10:1 compared to boys. Treatment failure is quite poor in type 1, unlike in type 2. In terms of relapse of drug withdrawal, it's also variable compared to type 2. But the most important thing to highlight is the characteristic of autoantibodies, because even in IM, these are the way to differentiate these two is quite highlighted. Okay, so this is the findings you can see on liver biopsy. See in a normal liver, you can see here there's no lymphocyte infiltration. It's just a normal condition. But in autoimmune hepatitis, you can see lymphocyte infiltration. Okay, apart from that, you have infection cause, which includes like viral hepatitis A, B, E. A usually is spontaneously resolved, but B, you need treatment such as interferon. E usually resolve. HSV, herpes simplex virus, can also cause acute liver failure. Epstein-Barr virus, cytomegalovirus, and this one is very common, leptospirosis and dengue. Which we give for leptospirosis, we give management of antibiotics, and for dengue, we have to give a strict supportive treatment. Okay, history-wise, how do we approach? So, how do we approach such cases of liver failure? We have to see evidence of jaundice. We have to see evidence of personality changes because of hepatic encephalopathy. Patient could also have lethargy, poor feeding. So the poor feeding could be evidenced by poor sucking or interrupted feeding. This could also be a vague suggestion for acute liver failure. Okay, hepatic encephalopathy, intellectual deterioration, and hypoglycemia. These are all of the conditions we have to consider. In terms of jaundice, there's also slight differences because you can see that in neonates, usually is associated with unconjugated. The type of jaundice is usually unconjugated because mainly you have like cases of hemolysis, or you have immaturity of the liver. So the liver cannot conjugate rather well, unlike when in a later age is more associated with cases of elevated conjugated bilirubin, especially in chronic liver disease. So these are one of the few differences between acute liver failure and chronic liver failure. So based on sunflower, they say in prolonged neonatal jaundice, it is the most common presentation of liver disease in neonatal period of more than 20 micromole per liter. Vital in case of biliary atresia, as the early diagnosis leads to better prognosis. Okay. All right. So infective causes, you have to see whether the patient have fever, vomiting, or history of contact. So tanya fever, mungkin dia ada leptospirosis. We have dengue, vomiting pun associated with leptospirosis or dengue, history of contact. Drug toxicity is important for where the patient could have been taking alternative medication is given by the parents, or the patient could have like acetaminophen overdose, paracetamol overdose. So these are the things to consider. Past medical history, we need to rule out the chronicity of the pathology. Because, why? Because it is one of the way to differentiate whether it is acute liver failure or chronic liver failure. But from that, we see any family history that could suggest for autoimmune hepatitis, type 1 or type 2, family history of Wilson's disease, because there is a genetic disposition in Wilson's disease. For birth history, we search for internal blood. You search for torch infection or prematurity. Developmental history, you see for a delayed developmental history or seizures. Seizures is a high risk in cases of inborn error of metabolism. Yeah. So these are from sunflower. You can see what are the features of liver disease. So you can see in liver disease, you can have things such as encephalopathy, jaundice, epistaxis, coagulopathy, ascites, hypotonia, peripheral neuropathy. Whereas this one is the complication of liver disease. You can have portal hypertension, spider nevi, muscle wasting from malnutrition, bruising, petechiae. Splenomegaly is important in PE, hypersplenism. Hepatorenal failure could also be evident in such cases. Clubbing or loss of fat, secondary to malnutrition. So in hepatitis encephalopathy, may be present with personality changes. Patient could be irritable or apathetic. Patient at times could be high aggression and irritability. There's a lot of behavioral changes you can see in hepatitis encephalopathy, but this usually occurs in a very severe cases lah. Intellectual deterioration or insomnia. So based on PITS protocol, you can grade the extent of the severity of the hepatitis encephalopathy. This stage 1, which is patient could have a prodrome stage, stage 2, impending, stage 3, stupor, and stage 4, coma. So in 1, you have slight atelectasis, which is like the flapping tremor, which is slight and very minimal EEG changes. And clinical manifestation, you can present with mild intellectual impairment or disturbed sleep-wake cycle. For stage 2, it's easily elicited. It's easy to elicit the flapping tremor, usually generating slowing of rhythm. Because we also do EEG at times. Drowsiness, it can come also with drowsiness, confusion, and coma. And stage 3, present if patient is cooperative, gross on EEG, grossly abnormal or slowing, drowsy and unresponsive to verbal commands. So stage 4, I'm not quite sure because they say the atelectasis is quite absent, usually absent. But in the case of coma, I'm not sure how it could be present because patient is in coma. But I'm not sure. I would like to ask further on this. I'm a bit confused. Apart from that, the EEG changes, you can see appearance of delta waves or decreased amplitudes. Okay. So this is how we assess the severity. We assess for child classification. We assess for encephalopathy and ascites, and then we grade from grade 1, 2, and 3. And then for lab investigation, we assess for bilirubin, albumin, and proton beam time. And these are the values we consider. From that, we can have we can put into the class A, class B, or class C for the child path classification. Where 5 to 6 is the least severe of liver disease, 7 to 9 is moderate severe liver disease, 10 to 15 is the most severe. In some cases, usually they do constructional apraxia, whereby they ask to draw stars, but I'm not sure whether to what extent it is being done in pediatric cases, because in cases of hepatitis encephalopathy, usually we do constructional apraxia, we want to see the extent of the control, the abnormality in the patient. If it's severe, usually you can have cases like whereby patient could be unable to draw, whereby at times when it is rather mild, you can have a perfect star. Okay, investigations. So investigations, what we would do, we would do things like for lab investigation, we do full blood count, coagulation screening, liver function test, renal function test, serum ammonia and glucose. So what we would like to see, we like to rule out all the differentials we would like to we consider. So we will look for thrombocytopenia, we will look for high evidence of infection, which is high white blood cell, or we can search for low ABC, low WC for aplastic. Coagulation screening, you see for prolonged PT or PTT, INR. This one is important for a diagnosis of the liver failure. You want to see changes in PT and INR mainly. And for the liver function test, you see for hyperbilirubinemia, albumin, creatinine albumin, aminotransferase more than 1000, and ALP semua. So renal function test is really important because why? It is associated with one of the complications of the liver failure, which is hepatorenal syndrome. The hepatorenal syndrome, the main pathophysiology behind it is renal vasoconstriction. So when patients have liver pathology, there is association with renal vasoconstriction. It is one of the main reasons why we do the renal function test. But from that, you can have elevated serum ammonia, especially in cases of inborn error of metabolism, which include the urea cycle defect as mentioned previously, and you can have a low serum glucose. Okay. You do for infective cause, you look for viral serology for Hep A, Hep B, and Hep C, and autoimmune markers for autoimmune hepatitis. You see for ANA and asthma, especially in case of type 1 autoimmune hepatitis. Yeah, and we can see elevated immunoglobulin of IgG in autoimmune hepatitis. Wilson's disease, serum and urine copper. You can have low seroplasmin, and we can assess for total serum copper. Drug, if it's indicated, you can assess for serum acetaminophen. It's important because even to how much NAC you want to give in the patient, you also need to assess how much of the acetaminophen is in the blood, because that will affect the content and whether you want to stop or you want to still continue with the NAC administration. And also you can give septic screening. Okay, so imaging wise, what we would do. So imaging wise, we would do abdominal ultrasound. You can do with Doppler. You want to see evidence of ascites, patency and flow of hepatic vessels and portal vein. So even in such cases of like Budd-Chiari syndrome, you want to see any evidence of the occlusion or ascites is also considered, and you want to assess to what extent the grade of the ascites. For EEG, you want to see you want to assess how severe of the hepatic encephalopathy, because as you can see in the PITS protocol, they have different changes of EEG in the different stage of the hepatic encephalopathy. CT brain, because at times hepatic encephalopathy is associated with cerebral edema, and even in the management afterwards, you will see that there are certain management which is associated in the management of cerebral edema. So stage of EEG, you can see there are the differences whereby you can see in clinical state of alert, drowsy, stuporous, coma, and deep coma. They have different stage of EEG. Principle of management. So how do we approach cases of acute liver failure? So the main thing, first things first, you resuscitate. And secondly, it's important for us to know the differentials, as what I've been mentioned previously. So we need to know, we have to bear in mind that patient could have inborn error metabolism, patient could have the toxic causes of the acute liver failure, patient could have things such as autoimmune hepatitis. So this one is important so that you can anticipate and you can consider what are the possible complications. And lastly, we consider for liver transplant if required. So management-wise, what we do, generally, the general measures, what we do close monitoring in quiet darkened room with head elevated at 20 degree without flexion. So this is mainly to assist in the managing the cerebral edema. And also we should not sedate the patient unless ventilated, maintain oxygenation, and frequent neurological observation 1 to 4 hourly. Vitamin K to prolong the PT. If frank bleeding, consider the use of fresh frozen plasma and cryoprecipitate. Prophylactic H antagonist or PPI, and full septic screening. So these are the general measures for cases of acute liver failure. So when do we consider liver transplantation? So among the indication of liver transplantation is when you have a case of severely malnourished case whereby it is unresponsive to nutritional therapy, or patient could have FTT or poor quality of life. These are among the indications of liver transplantation. So it is divided into acetaminophen induced acute liver failure or non-acetaminophen induced. So you can see if it's acetaminophen induced, you see if the pH is less than 7.3, if it's more than 3 millimole per liter after adequate fluid resuscitation. So for non-acetaminophen induced, you see the INR level and you see evidence of encephalopathy present. And apart from that, or if any 3 of the following features are present, you can see whether the age is less than 10 or more than 40. You look at the interval from jaundice to encephalopathy, whether it is more than 7 days. Assess the INR, whether it is more than 3.5 or more, and you assess the serum bilirubin, which is if it's more than 3 micromole per liter or not. So there are cases whereby it is contraindicated for liver transplantation, and that the absolute contraindication will include things such as fixed and dilated pupil, uncontrolled sepsis, severe respiratory failure, and if patient have HCC, however, for relative contraindication, we will include things such as increasing inotropic requirement. So these are for acute liver failure. For chronic liver failure, the differential is rather similar, but whether there was just slight differences. So for chronic liver failure, you can see that this is defined as a long-standing, irreversible change in the hepatic structure. Okay, long-standing, irreversible change in hepatic structure, which may end in complications such as cirrhosis, and which leads to premature death. So the commonest cause of this chronic liver failure, one of the most commonest cause is infection, hepatitis B and hepatitis C. This one is of the commonest cause based on sunflower. And also in certain cases, Wilson's disease should be excluded in certain cases. But the most common is still infective cause. Okay, so so you can see the causative conditions can be congenital or acquired. So for chronic liver disease, we divide whether it's congenital or acquired. So for the major congenital disorder, it would be things such as biliary atresia, tyrosinemia, untreated galactosemia, or alpha-1 antitrypsin deficiency. So I would like to focus on the biliary atresia. So in biliary atresia, mainly what you have the, if you can see here, you have the atresia of the biliary duct. So when you have the atresia, so you have problem, we have like a form of obstruction. When the flow is obstructed, you have a lot of this conjugated bilirubin in the blood, which can cause a patient to have like jaundice. And apart from that, mainly it can cause the liver failure. So in such cases, what is the golden investigation you would like to do? So the golden investigation is liver biopsy. Why we do liver biopsy? Because at times there are changes, histological changes inside the liver, which could suggest that patient could have biliary atresia, because it's not, at times it's not really easy to identify the biliary atresia. You can do liver biopsy. You can also do abdominal ultrasound for absence of the gallbladder. And how do we treat case of biliary atresia? We do Kasai procedure. In Kasai procedure mainly is basically it's a hepatoportoenterostomy, which is a surgical bypass. We want to bypass the atresia so that the flow is not obstructed. Okay, in older children, its causes include, like as mentioned previously, hepatitis B, hepatitis C, autoimmune hepatitis, Wilson's disease, primary sclerosing cholangitis, cystic fibrosis, biliary obstruction, secondary to choledochosis. Okay, so for the this one, I'm talking about a presence of we can have presence of NFL and NASH. So this is the pathophysiology from a normal liver to cirrhosis. And basically what we have, you can have from a normal liver, it can become pathologic to form a fatty liver, and from this fatty liver, it can cause the steatohepatitis, and this is a non-alcoholic steatohepatitis, which can later fibrose to cause cirrhosis. So in these cases, usually associated in patient with dyslipidemia and type 2 diabetes, which is not common in kids. But then you can have, it's commonly highly suspicious in cases of obesity. Okay, so the changes, physical signs, physical examination, you see ascites, you can see evidence of cirrhosis, which is not evident in acute liver failure. It can also happen in case of allergic syndrome. However, based on Nelson, progression to end-stage liver disease is very uncommon unless it's not treated. So these are one of the things you need to consider. You see a patient with dysmorphic features, prominent forehead, deep-seated eyes, pointed chin, bulbous tip of nose, evidence of heart disease, butterfly vertebrae, and posterior embryotoxon. Patient can also have a pulmonary stenosis as the cardiac abnormality there. So for the imaging wise, what you can do for chronic liver disease, you see evidence of ultrasound of the liver. You want to compare the histology. If you can see in a normal liver, you can see the hepatic veins, the portal veins rather well. But in liver cirrhosis, you see there is evidence of surface nodularity. And apart from that, you can have signs of complication of chronic liver failure, and which is the signs of portal hypertension. And there is evidence by presence of dilated portal vein more than 13 millimeter, any evidence of splenomegaly or any ascites or any fatty changes in the ultrasound of the liver. So this one of the main investigation to see whether the patient could have chronic liver disease or not. Okay. Sorry. So for the management, so the approach is that we want to, for patient with ascites, we want to restrict the sodium intake. We want to restrict fluid and monitor renal function, input and output chart. We want to monitor if there's any abdominal pain. Nutritional compromise, you want to ensure that patient is adequately have enough nutrition, because patient could have reduced nutrition, especially in cases whereby patient have poor oral intake or poor low in appetite. And hepatic encephalopathy, you have the measures. Mainly we have to ensure that we want to ensure that the patient have enough bowel output of at least 3-4 per day, because we don't want a retention of the stool, as it can exacerbate the hepatic encephalopathy due to the uptake of the ammonia. So we are in cases whereby patient do not reach a certain bowel output per day, we need to consider giving lactulose. Okay, so these are the approach of for chronic liver disease. Okay, so these are my references. Any questions, or I shall pass to the next presenter.
Okay, any questions?
I would like to ask regarding the PCM overdose just now.
Yes.
So for the management, is there any role for the gastric lavage, and is it practically done? Like within how many hours it is done, or after how many hours?
For gastric lavage, I'm not sure, because I read about some phenobarbital poisoning, but for the paracetamol, I'm not really sure about the gastric lavage.
Paracetamol, we give the activated charcoal, and we do gastric lavage on paracetamol. If it's early lah, if not, then we don't do. Okay, but we do, we give actually gastric lavage dengan activated charcoal ni is about the same lah. It's the same procedure. Cuma gastric lavage tu we don't put charcoal lah. Tapi for PCM overdose we give charcoal, and also we do gastric lavage if it is early presentation.
Doctor, the early mean, is it within 1 hour of
1 hour.
ingestion? Oh, okay, thank you, Doctor.
Actually 1 hour lah. Actually the reference is 1 hour, but we practically we accept even 12 hours pun kita buat, because we don't want to, we have to use all modalities now, because PCM overdose is a medical emergency, because they will fail, the liver will fail. And problem in Malaysia is we don't do transplant in pediatric. So you have to wish that the children are lifelong enough to become adulthood, and then the adult can do transplant. But we don't do many transplant, liver transplant. Liver transplant is very difficult, because even though liver is a promising organ for transplant because it can regenerate, but the procedure is very dangerous and very difficult, because liver, there's a lot of blood supply to the liver. Intra-op mortality is very high. The outcome is very good. If successful, it's very good. It's one of the best. After, I think maybe second after renal transplant, but yet the procedure is very risky. So usually in pediatric liver failure, we maintain them, make sure they can live up to adulthood, then we refer to adult.
Okay, thank you, Doctor.
Any other questions?
Doctor.
Actually, I just want to add a bit. Okay? So what do you understand about IEM? Inborn error of metabolism.
in bone area botulism, from what I understand, mainly is there's a lot to do with the deficiency in important enzyme for metabolism, and that will include things such as in urea cycle, in formation of carbohydrate metabolism. That's to be included. And usually it's clinically it's very difficult to identify because it's so subtle. That is from my understanding.
Okay, you're quite right. So basically, when we say metabolism, any metabolism can have defect in our body. Any metabolism, okay, it's either your minerals, metabolism of your minerals, for example, like Wilson kan, copper punya metabolism, iron metabolism, carbohydrate metabolism, protein metabolism, your oxygen transport chain, anything, any metabolism in the body will require enzyme. Okay, and because it's a process kan. All this metabolism happen in process. Okay, in stages. So in each stages they will require an enzyme. So any defect in any of these enzymes, so in your body there'll be like hundreds of thousands of metabolism, hundreds of thousands of enzymatic catalyzed reaction occurred in your body every second kan. So all this enzyme can be defected. Okay, so in IEM it's actually genetic disease. Most of the time it's a genetic disease. Actually all the time it's genetic disease. And most of the time it's actually a monogenetic lah, we call it monogenetic. It's a single mutation. Most of it is single mutation or deletion that cause defect in the gene of the enzyme. Okay, so for example, galactosemia. Galactosemia is the problem with the enzyme. What we call it? Glucosidase. I can't remember the name. GDP, something lah. And then galactosemia, tyrosinemia, as a name reflects, it's a amino acid problem kan, neurocycle defect. So you've got problem in production of your metabolites such as ammonia and urea, things like that lah. So basically so IM can happen everywhere. Okay, and most of the time it's not subtle. It's not subtle. Some of them are subtle. Okay, you can have subtle presentation. For example, like jaundice kan, apa nama, Gilbert syndrome. For example, like Gilbert syndrome. These are actually the subtle because a lot of people they grow up with it and no one cares about it. But most of the disease are not subtle. Some are actually transient. You know, like you can have a child with a dramatic liver problem, conjugated hyperbilirubinemia, for example, like in citrullinemia. They can become very bad. You're very worried about them, but after 1 year old, it resolves. That's why in pediatric liver transplant, it's not like in adult, because most liver transplant in adult is actually caused by acquired disease, self-inflicting disease, especially, you know, like sexual transmitted disease, Hep B, alcohol, kan, steroid, things like this. But in pediatric, a lot of the diagnoses are unknown because these are actually contributed by the genetic and also metabolic components. And a lot of metabolic disease are actually cannot be diagnosed. Okay, there's still lack of modalities for diagnosis. Enzyme screening, and also genetic screening, still we are lacking. So a lot of pediatric patient, we don't have diagnosis upon transplant. And a lot of this case, I think it's about 20 to 30% of this case, after transplant, the native liver recovered. So there are questions whether should we actually transplant them in the first place. Because what happened is, we used to transplant everyone in the past. I think in the 1990s, in 2000, we used to transplant every pediatric liver failure. But after a while, now there are stricter criteria for transplant. And in fact, even with stricter criteria, the mortality and also the outcome are similar. So even though we are transplant less pediatric patient, I mean, less disease is transplantable in the list of pediatric transplant, the mortality and morbidity is the same. Mortality rate is the same, means those who are not transplant still living. Okay, because a lot of this condition is actually they recovered by themselves, because liver is a very strong organ. They can rejuvenate, kan? So sometimes this happen lah. So in pediatric, the transplant in pediatric, usually a lot of time our management is conservative. We try to prolong life, and hopefully it recovered. Okay, so that's why we got the compensated and decompensated chronic liver disease. Because sometimes they develop chronic liver disease for years, and suddenly they compensate and they recover. Especially like Hep B lah, chronic, especially this chronic infection and Hep B. There are different phases of Hep B and different phenotype lah. So anyway, so I think for Wilson, okay, for Wilson it's quite important to diagnose, to have high degree of suspicion in Wilson. Okay, Wilson in general, they can present in two phenotype, either neuropsychiatric problem or liver problem. Usually they don't come with those two lah. Pediatric, most of the time they come with liver problems. So Wilson with liver problems, pediatric Wilson usually presented with liver failure. Okay, while adult Wilson, they usually presented with neuropsychiatric rather than liver problem. So if you go to psychiatric ward, if you see like 10 people, if you see young people at the age of like 20 with schizophrenia, I can bet you at least 50% of them got Wilson. Okay, it's undetected. Adult, of course, adult internal medicine is, I mean, they are not as concerning. I mean, they are not as caring as pediatric. And so pediatric, we screen Wilson more than adult lah. A lot of Wilson in adult are not diagnosed, especially those in the psychiatric ward. Anyway, so for the obstructive lesion, the most important, you've got two lah, the biliary atresia and also the Budd-Chiari, kan? So the Budd-Chiari is actually, these are obstructive lesion. Budd-Chiari is actually is obstruction at the level of hepatic vein. So it's the liver outlet. Okay, just remember, liver outlet obstruction. Budd-Chiari is liver outlet obstruction. So it leads to congestion of the liver, because liver cannot, I mean, output of liver output, there's no liver output, kan? Liver dia punya output through two veins lah, portal circulation and also the systemic circulation. Okay, tapi because the systemic, which is the vein, hepatic vein is obstructed, so they congested the liver, so liver damage. Okay, usually Budd-Chiari, as you correctly mentioned, is a chronic disease. In pediatric, a lot of them come on and off with jaundice. Okay, you just monitor them. Usually every 6 months, you do like ultrasound, monitor the size. After, if they've developed like persistent jaundice and sign of liver injury, then only you opt. It depends lah. If they've got like total obstruction of hepatic vein, they die very early lah, during young childhood. Tapi if they got like only 2 or 1 obstruction, most of the time we can postpone the operation. Right. Actually, we've got one patient, I think in March this year, back in Kelantan lah, with Budd-Chiari, and that finally, I mean, come with, she's got this frequent abdo pain and jaundice. Abdo pain with jaundice, like ascending cholangitis, kan, or ascending cholangitis features. Finally we decide to operate now. So at the end, I think that's time for operation, so we send her over to surgical. So that is part carry. For biliary atresia, it's actually obstruction because of atretic bile outlet lah, biliary outlet. So what happened is, again, because liver produce the bile and store it at the bile duct, and then from bile duct is secreted, excreted. No, I mean it's secreted into the duodenum kan. So any obstruction from the ampulla of Vetter, for example, like choledochocystitis, and proximally up to the biliary tree, biliary tree, any obstruction at this area can obstruct the bile outflow, and cause retrograde influx of bile into the liver, which can damage the hepatocytes. Actually, diagnosing gold standard is actually HIDA scan. It's not ultrasound. You cannot ultrasound. Most of the time, it's not specific, no sensitive. So it has to be HIDA scan lah. It's a gold standard. HIDA scan, but problem is not many center can do HIDA scan. A lot of time we do HIDA scan on table. So I think in KL they do on table HIDA scan. So once diagnosed, they open and do Kasai lah. Because Kasai need to do as early as possible. Even with if you do Kasai within the first 1 month or 1 to 3 months of life, the success rate is only about 80%. So a lot of Kasai actually fail after a while. Okay lah, tu cukup. Can we rest first before we proceed?
Yeah.
Okay, let's have a rest. Maybe 10 to 15 minutes. We meet again at 10:25. Can we?
10:25. Kira dah.
Okay. Okay, Sakom, semua ada dah. Dengar?
Dengar doktor?
Okay, semua ada dah. Good, good. So let's continue on the last one.
Can I proceed?
Okay, yes, please.
Bismillahirrahmanirrahim. So I'm Anissa. Today I'll be presenting about functional abdominal pain. So I hope you can stay with me up until the end. I try to be brief as I can. Okay. So tak gerak. Okay, so this is outline for my presentation. I will start with intro and definition, then pathophysiology, classification, clinical presentation, red flags, clinical approach, management, and last, I will end with prognosis. So let's go to the first part, the introduction. I will talk about chronic abdominal pain because the FAP, functional abdominal pain, is actually characterized under chronic abdominal pain. So as FAP, the most common cause of chronic abdominal pain in children and also adolescents, the incidence is about 9 to 15% of children and about 13% middle school and 17% high school having a weekly abdominal pain. The peak age is between 7 to 12 years old. And the chronic abdominal pain can be defined by 4 criteria. The first is 3 or more episodes of pain sufficiently severe to affect the activity, and then episode occurs over the period of 3 and more months, and no known for organic cause. So chronic abdominal pain, also defined as long-lasting, intermittent, or constant abdominal pain. It can be divided into 2 causes, the organic, which is disease-based, and the non-organic, the functional one that we are going to talk about today. So the functional is defined as it refers to pain without evidence of anatomic, inflammatory, metabolic, or neoplastic abnormalities. Okay, FAPD, functional abdominal pain disorder, previously called as pain predominant functional gastrointestinal disorder, FGID. It is defined as combination of chronic and recurrent GI symptom, not as pain by structural or biochemical abnormalities. And synonymously, it also named as recurrent abdominal pain, which also means at least 3 episodes of pain over at least 3 months that interfere with the function. However, we already use the other new term, which is chronic abdominal pain, instead of recurrent abdominal pain. And for your information, that FADS is a symptom-based diagnosis made by Rome 4 criteria 2016. And this is the new addition from the previous criteria, Rome 3, where after appropriate medical evaluation, the symptoms cannot be attributed to another medical condition. Compared to the previous one, the Rome 3 criteria, it says that there is no evidence of organic disease. Means that if from the new term, it's allowed that the clinician to do less tests or no tests to support the positive diagnosis of FGID or FAP. And this new term also allowed that the FAP or FGID to be coexist with other diseases such as IBD. Then pathophysiology, it is said to be complex and not fully understood. However, it involves enteric nervous system, the ENS, the gut brain, and also CNS, central nervous system. There are 2 theories that support the pathophysiology of FAP. The first is brain gut axis dysregulation, and the second one is the visceral hypersensitivity. So for the first theory, the brain gut axis dysregulation, where the brain having an inability to turn down the pain signal. And so the gut having an abnormal reaction of stimuli, which whereby a normal human will have a normal reaction to it. But however, in the patient with FAP, they're having an abnormal interpretation of the stimuli, such as physiological stimuli like meals, gut distension or hormonal changes, or second noxious stressful stimuli like inflammatory process and The most important part is psychological stressful, like parental separation and anxiety. So all this small amount of intestinal disturbance or external stressful stimuli will amplify the severity of the pain, and the patient or the child might have a low threshold of pain. And the second one is visceral hypersensitivity. It's happened when the child having a sensitization of afferent nerve from the previous mucosal inflammatory process, such as infections, allergies, or primary inflammatory disease. And this sensitization will decrease the threshold of pain in FAP patient. So even normal stimuli may be perceived as noxious or severe pain. And then classification or criteria. There are four types of disease under FADS, FAPS, FAPD. So there are, first is irritable bowel syndrome, IBS. Second is functional abdominal pain syndrome, not otherwise specified, or called as FAPS and OS. And the third is abdominal migraine, and the last is functional dyspepsia. So basically, FAPS and OS is where a diagnosis made when the symptom doesn't fit in any other three diagnoses, the IBS, AM, and FT. And bear in mind, you have to, for all these criteria, there are universal criteria, where I mentioned before, that after appropriate evaluation, the symptom cannot be fully explained by any other organic disease. Okay. So let's go to the criteria. The first is IBS, irritable bowel syndrome. At least 4 days per month for at least 2 months, abdominal discomfort or pain associated with one of the following. The first is improved with defecation, change in frequency of stool, and last, change in stool form. So in children with constipation, if the abdominal pain does not resolve, usually the abdominal pain does not resolve with resolution of the constipation, because if the pain resolves with resolution of constipation, it might indicate functional constipation instead of FAP or IBS. And the second is FAPS and OS, at least 4 times per week for at least 2 months. The pain is episodic or continuous that does not occur solely during physiological events, such as eating or menses. And the last is insufficient criteria for IBS, functional dyspepsia, or abdominal migraine. Like I said before, it is a criteria that doesn't fit in any 3 other criteria. And for abdominal migraine, must include all of the below. First is paroxysmal episode of intense acute periumbilical, midline or diffuse pain in the last 1 hour or more than 2 times over the 6-month durations. Second is intervening period of usual health, lasting for weeks to months. Third, the pain interfere with normal activity. For the second intervening period of usual health lasting for weeks to months is same like the normal migraine that's happened at the head. So, and the fourth is stereotypical pattern and symptom in the individual patient. The last is the pain associated with 2 or more of the following: the anorexia, nausea, vomiting, headache, photophobia, or pallor. And the last is functional dyspepsia, at least 2 months for at least 4 days per month of 1 or more of following: the postprandial fullness, early cessation, and epigastric pain or burning that associated with defecation, that not associated with defecation. Okay. So let's go to the clinical presentation. As we know that FAP is abdominal pain, so we go with the Socrates mnemonic. So as its site, it is poorly localized, basically at periumbilical, and some say in Nelson it might happen at the splenic or hepatic flexure pain. For the onset, it is recurrent and chronic. It can be sudden and may worsen throughout the period. For characteristic, is a dull because it's a visceral organ, and then crampy or intermittent. For the radiation, no radiation, and associated symptom, it might be associated with autonomic features such as pale, nausea, dizziness, headache, or fatigue. And others are anorexia, excessive gas like dyspepsia, joint pain, diarrhea, or constipation. And It also associated with anxiety or depression or any tendency towards anxiety and perfectionism. And for the time or duration, usually it lasts for 2 hours, but some say it can happen less than 1 hour. And for the exacerbating factor, it is exacerbated by stress. For example, like school transition, parental divorce, emotional trauma, or even parental separation. And it can resolve spontaneously without any medication as the child get relaxed. And the severity often worse at morning, which prevent or delay the child from going to school. And other history like family history of GI disorder, for example, like IBS or constipation, or even anxiety disorder. And it's more common found in obese child. And for the HOPI, we also need to ask for red signs because red signs indicate FAP. No red sign indicate FAP. If there is any red sign, it's indication for the investigation of other organic causes. So this is the red symptom and sign. So we go to for the alarming symptom first. The first is pain that wake up the child from sleep. Basically, it's severe. Persistent right upper or right lower quadrant pain, not at the periumbilical, means that this can indicate other causes. And then significant vomiting, unexplained fever, genital urinary tract symptom, which can also suggest obstructive uropathy, dysphagia, chronic severe diarrhea or nocturnal diarrhea, gastrointestinal blood loss, involuntary weight loss, deceleration of linear growth, delayed puberty, and family history of IBD, celiac disease, and peptic ulcer disease. For the signs, same, the tenderness at other part of the abdomen, aside from the periumbilical, localized fullness of mass that might suggest any benign or malignant cause, hepatomegaly, splenomegaly, jaundice, costovertebral angle tenderness, arthritis, spinal tenderness, perianal disease, abnormal or unexplained physical finding, hematochezia, and anemia. Okay. So these are the example for the red signs that might indicate potential significant disease like involuntary weight loss may indicate malabsorption in IBD, celiac disease, or pancreatitis, or even in malignancy. And you can read later on about on this list. The same goes to the examination. Like in IBD, we can find oral uptus ulceration. So this is the differential diagnosis. The most common after the FAP is chronic constipation, and others could be peptic ulcer disease, where the patient may present with burning pain in the epigastric area, celiac disease, diarrhea, as Sohi mentioned before, lactose intolerance, also diarrhea, parasitic infection, giardiasis, IBD, esophagitis, recurrent intest, and chronic appendicitis. So these are the other list of chronic abdominal pain in children from Nelson. You can read later on for further future reference. And how to approach this case? First, from the history, we can find out about the chronic abdominal pain, plus no red or warning sign and symptom. Then we go to the physical examination and lab finding, where there will be normal finding. And plus, we do the fecal occult blood test, which show normal finding also. On all these 4 components, we lead to diagnosis of initial FAP. And this didn't need and warrant any further investigations. So first, like I said before, initial evaluation, we start with history plus warning sign, and then we assess for the functional impairment like missing school before, and then we can proceed with the investigation, the full blood count, the ESR, amylase, lipase, urinalysis, and abdominal ultrasounds to examine liver, bile duct, gallbladder, pancreas, kidney, or ureter. And we can also suggest to do the trial while waiting for the investigation, do a trial of 3-day lactose-free diet to rule out or to suspect for any lactose intolerance. If there is any improvement in the symptom, we can suggest lactose intolerance. And there are also other additional initial investigation to reassure the parents, although the diagnosis of AAP is already suspected. So for example, like celiac panel, because celiac disease is having in patient with FAP, they're having a higher risk, like 4 times, to have a celiac disease. So we can do TTG or IgE serology for stool culture or stool for oval and cyst. For Helicobacter pylori, for PUD, we can do fecal antigen Helicobacter pylori. And like the doctor mentioned before, lactose intolerance to the breath hydrogen breath test. And if we suspected any stomach or bowel cause, we can do abdominal X-ray. And for the management, basically we aim the child to function well and minimizing the pain. So there are 4 components for the FAP. The first is reassurance plus education, second psychotherapy, third dietary, and last is pharmacotherapy. Let's go to the first management, which is the most important component in FAP, reassurance and educate. We have to eliminate the fear of unknown in the parents by validating the symptom of the symptom of pain is real, but it's not related to any dangerous or serious underlying disease. And then we must have the child to return to regular activity and school as soon as possible. So as the child goes to school, he or she might be having a severe or intense pain. But we can, instead of sending the child going back to home, we can ask the child to have a break from the classes until the symptom abate. And then we must inform also the parents and the child regarding the severity of the pain or worsening of the symptom upon returning to the schools. Okay, and then do a close following and counseling. And if needed, we might do some lab tests for reassurance. And the second is also the important part for management in FAP is psychotherapy, because it is related somehow to the psychology. So we refer psychiatry if there is any identified psychiatric illness or tendency. And then we might suggest biofeedback or guided imagery. Basically, biofeedback is a technique that allows patient to control its body function, like heart rate. So in this case, we can help the patient to control by doing muscle relaxation, and the muscle relaxation can help the patient to reduce the pain. And others are relaxation techniques, or we can do also cognitive behavioral therapy, the short term for managing pain and functional disability. So for CBT, we can change the negative thought of pain to the newer alternative positive thought. And others, psychotherapy can be family therapy and hypnotherapy. And the third is dietary, although it's not proven to be helpful, but somehow it might be helpful in some patients. So for fiber, we can add fiber, or if the patient doesn't want to eat fiber, we can give supplement because it helps in the gut motility. And second, specific elimination, because lactose and fructose somehow might be related to FAP. And if there is presence of bloating, we can suggest low FODMAP diet. FODMAP stands for fermentable oligosaccharide, disaccharide, monosaccharide, and polyols. Basically, it is a carbohydrate-derived diet, because carbohydrate we know having a late absorption and so rapid fermentation by the bacterial gut, which change it into the formation of gas, which then lead to the bloating. So if we reduce it, we can reduce the bloating. And the last part in management is pharmacotherapy. So as I mentioned before, it is related to psychology. So we can give SSRI, selective serotonin reuptake inhibitor, because somehow the serotonin effect has an effect on GI, which increase mortality. Or we can suggest TCA, tricyclic acid, which having norepinephrine mediated reduction in pain or anticholinergic effect. Others include antispasmodic medication, which is low dose amitriptyline, peppermint oil or menthol in IBS. Dyspepsia, we can give PPI, proton pump inhibitor like omeprazole, pantoprazole, or H2 antagonist like cimetidine or ranitidine. And then IBS, anti-diarrhea if patient presented with diarrhea, or non-supinative laxative if patient presented with constipation. So as you can see below, this is a table of effectiveness of treatment in FAP. And somehow only CBT, which related to psychology, is beneficial beneficial to the patient. Otherwise, the other management like dietary somehow doesn't really help in resolving the pain. But we can just opt or suggest to the patient. And for prognosis, FAP improve with time, and most children will be able to grow out of it. So that's all for my presentation. These are my references.
Okay, good. Okay, any questions? I think Anissa is more expert in functional disorder than I am. So ask Anissa. Okay, got any question at all? So what do you understand about functional disorder? What is the most common functional disorder that we, as adult, we ourselves encounter, daily practice among family members ke?
IBS, brother.
IBS. IBS is quite common, betul. Migraine lah kan. I think migraine is more common. I'm not sure about epidemiology lah, tapi migraine, I think everyone claim they got migraine kan. Once they got headache, they say they've got migraine. So migraine is actually one of the most common lah. It's a functional disorder lah, functional disorder. And functional it doesn't mean it's not similar to psychological disorder tau, but they come together most of the time. Okay. Lagi anything else? Nak tanya soalan? Can you go to the slide yang H. pylori tadi ke?
Oh, this one.
Yeah, this one. Apparently, I'm not sure lah in Malaysia macam, tapi when I was in my undergrad, H. pylori eradication therapy is a must for everyone with dyspepsia lah, peptic ulcer lah, with peptic ulcer. So basically H. pylori macam worldwide, H. pylori is the most common cause of treatable cause of peptic ulcer. But in Malaysia, H. pylori is very rare. It's rare, I think, because we are underdiagnosed. And the best thing is almost non-existent dekat Kelantan. The only states in Malaysia yang H. pylori ni is very rare is actually dekat Kelantan. Other states memang ada states lah, kalau macam even Pahang, Terengganu pun, patient with peptic ulcer, adult lah with peptic ulcer, kita akan investigate for H. pylori. In pediatric, we rarely investigate for H. pylori. Because pediatric dia tak cooperate with the procedure kan. Tapi in Kelantan kan, data memang shows H. pylori is very rare dekat Kelantan. Not sure because dia makan budu ataupun makan sayur, tak tahu. Makan banyak ulam ke tak tahu, tapi it's very rare. Tapi in Pahang I'm not sure lah. Tapi H. pylori ni in UK is very common. In developed country is very common. It's almost always certainly need to be investigated in anyone presented with peptic ulcer or abdominal pain. Okay. Any other questions ke? Saya tanya Nisa. But in general lah, for functional disorder, it's similar to psychological disorder. The diagnosis is made based on a criteria, based on diagnostic criteria. Okay, it's not based on investigation or physical examination. You have to, most of these are diagnosis of exclusion. So it's similar to like DSM-5, ICD-10. So for functional disorder, you use ROM criteria lah. Rome criteria for functional GI disorder. So you've got abdominal pain, you've got abdominal migraine, you've got abdominal pain syndrome. So these two is main lah for abdominal pain. Then you also got like others macam ruminant syndrome, globus pallidus, all these are actually functional disorder. And in order to diagnose, you have to fulfill the criteria lah. The most established criteria is the Rome criteria. So Rome 4 is not easily available. Rome 3 is easily available. So you boleh check lah. Tapi it's common. Okay. Functional constipation is also a functional disorder. So you need a proper, you need to fulfill the criteria before you diagnose functional constipation. That is the criteria. Okay, anything else for this?
Doctor, can I ask for this patient, will they have a condition that requiring admission?
Yes, they do. They do admit a lot of time. They admit regularly. Believe me, you'll see this patient regularly in your ward. Especially those who functional abdominal pain syndrome in very young children, they do admitted because of pain control lah. Most of them because of pain control. Biasanya you just give them drip, bagi PCM sikit. Sometimes you give tramadol. And after 24 hours, you discharge lah. They'll be happy and then you discharge them. But after a while, they'll come back. And again, you do all investigations negative. And after a few years of recurrent admission, they suddenly disappeared from your system lah. Defaulted and then gone. Similar to other functional disorder, for example, abdominal migraine. Abdominal migraine pun selalu masuk ward. And also cyclical vomiting, for example, kan. Cyclical vomiting, this is more frequent because sometimes they become dehydrated because of the cyclical vomiting. Every now and then, usually every 2-3 months, they will definitely come with dehydration. Vomiting, dehydrated. Then you give fluid. After 24-48 hours, they resolve, so they go home and come back after 2-3 months. So you will definitely see them. Even in fact, a lot of the referral through ED ataupun through KK kan, actually they belongs to these people now in this category, functional disorder. But remember, in pediatric, when you are facing the pediatric population and also the adult, the father, the parents, you don't dismiss them without enough reassurance. You have to educate and reassure them until they're confident. Because if not, you'll be facing legal action or you'll be facing mistrust or distrust from parents. Because adult is much easier to explain to them, oh, I think you've got this problem with the function of your bowel. But in pediatric, if mother came genuinely because of child in pain, in severe pain, they can become very severe. They can sometimes score 10, 9, and even we do occasionally need to give fentanyl or even morphine or fentanyl for these children. So you cannot disregard them as melancholy or things like that. Never, okay? They properly explain. The trick is a good consultation and explanation is the main medication for this disease. Okay, ada lagi? Okay, good. On time?
Okay, Doctor.
Tak ada kan? Okay lah, I think this is very lengthy session and very detailed. Good job. If you got any questions, you can always text me WhatsApp ke. If I can answer, then I'll answer. If not, I'll pass it to other lecturers. So you can search by your own. Nowadays, everything can be searched online. Anyway, okay lah, thanks for the effort. Okay, okay lah, kita tangguh lah dengan tasbih kafarah. Terus dengan suratul Nas. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Thank you,
Thank you,
Doctor.
Doctor.
Thank you, Doctor.
Thank you, Doctor.
Thank you, presenter.
Doctor.